Hello and welcome to part one of two presentations on the chest. So first we'll have a quick review of normal anatomy, and we'll look at the heart, the size and the contours. We'll look at the silhouette sign, and then we'll look at displacement in terms of whether the organs are pushed or pulled. And then we'll spend some time looking at the different types of lines and tubes that can be inserted and finish off with pneumothorax. Remember, this is part one of two presentations. Here are some of the learning resources used in the creation of this presentation. Here's a slide just showing you the normal presentation of the chest. You may wish to pause the slide just for a few seconds to remind yourself of all the normal anatomy before we proceed.
Our trachea is usually centrally located. However, it may branch slightly to the right as it moves to the right of the aorta. Our carina is at the level of the bifurcation of the trachea, which is at the level of the sternal angle and the fifth thoracic vertebra at rest. Our right bronchus is much shorter, it's wider, and it's much more vertically orientated in comparison to our left, which is much narrower and longer. It's for this reason that if we inhale a foreign body, it's much more likely to go down the right bronchus. Our hilar, these are our lung roots, and these anchor our lungs to the heart, the trachea, and the surrounding structures. The hilar consists of the major bronchi, the pulmonary veins and arteries. And as these structures pass through the narrow hilar, they then branch out into the lungs. So our left hilar is usually higher than our right. And this is because the left pulmonary artery passes over the left main bronchus, whereas our right main pulmonary artery passes in front of the right main bronchus. Now, in 5% of individuals, the hilar are at the same level. But the most important thing that I want you to remember is that the right hilar is never higher than the left. And so therefore, if the right hilar is higher than the left, you have to have a high level of suspicion that there's an abnormality. So our hilar should have smooth vessel margins and branching vessels. Any hilar that are lumpy bumpy, this is abnormal. So we have hilar lymph nodes, but these aren't visible on a chest x-ray, but they're very important. Because if you get hilar enlargement, it's normally due to the enlargement of these lymph nodes. So what does that mean radiographically? Well, if you get enlargement of the lymph nodes and enlargement of the hilar, this increases density. So check to see your height of your hilar to make sure that your right is never higher than the left, and check that your hilar both have a similar density. So things that cause hilar enlargement, this includes lymphadenopathy, tumours, pulmonary venous hypertension, pulmonary arterial hypertension, and increased pulmonary flow. So on this normal chest x-ray, what, where, how, normal study. It's helpful to divide the lungs into three zones: the upper, the middle and the lower. So each of these zones occupies approximately a third of the height of the lungs. Now, the important thing to understand is that these lung zones do not equate to lung lobes. So, for example, our right lower zone consists of the middle and lower lobes. So what you're looking to do is you compare each zone with the opposite side. And what you're paying attention to is asymmetry. So if you have asymmetry, you need to decide, is this due to technical factors such as rotation, or is it due to pathology? Often, one lung will appear more dense, i.e. white, than the other lung, such as pneumonia. But occasionally some diseases create the lung to be less dense, i.e. blacker, such as a pneumothorax. And just to make things challenging, occasionally some pathologies will be bilateral. The right lung has 3 lobes, whereas the left only has 2. The horizontal fissure separates the upper lobe from the middle, and it's often visible on a normal chest x-ray. And what you're looking for is a thin line that runs roughly horizontal from the edge of the lung to the right hilum. Both lungs have oblique fissures that separate the upper lobe from the lower lobes. And on the PA view, our costophrenic recesses, these represent our lower lobes. On our right side, the oblique fissure labelled B. At its most inferior portion, it's sited about 4 to 5 centimetres posterior to the sternum, and it separates the lower lobe from the middle lobe and the upper lobe. We can see that the majority of the diaphragm touches the lower lobe, whereas the majority of the inferior and the posterior heart borders touches the middle lobe. Only a very small amount of the diaphragm touches the middle lobe. The oblique fissure on the left lung, labelled B again, is in a similar location. But it's very interesting to note that the high position of the apical segment of the lower lobe is often not appreciated. So you can see that the lower lobe stretches very high or very superiorly in relation to the thorax. The pleura is a sac that envelops the lung. So it has 2 main membranous walls. We have our inner visceral pleura, which is in white, and then we have the outer parietal pleura, which is in the dark purple. Now the pleural space is the space between the visceral and the parietal pleura. It's a closed cavity. Now you're going to get a small amount of lubricating fluid that lies within this cavity, and usually the pleura are not visible on a normal chest x-ray, except where it forms part of the lung fissure and where the 2 lungs abut each other at the midline. The visceral pleura extends into and lines both sides of the fissures. The inferior extent of the posterior pleural space is considerable, and it's not obvious on the frontal chest x-ray. Pleural surfaces only become visible when there's an abnormality, such as pleural thickening, fluid within the pleural spaces, or air within the pleural spaces. The costophrenic recesses are formed by the hemidiaphragms meeting the chest wall, and where it forms the angle, this is referred to as the costophrenic angle. Now often the right hemidiaphragm is slightly higher than the left, and this is by one intercostal rib space, which is approximately 2 centimetres, and it's due to the underlying liver. The highest point of the diaphragm should always be centrally located, not at the lateral margins. When you have the left hemidiaphragm significantly higher than the right, then an underlying abnormality is likely. Quite often you can see the gastric bubble, and this is caused by air in the fundus of the stomach, and this is usually closely located to the hemidiaphragm. So it's always important to do a PA chest where possible, as we know that this reduces magnification to the heart. Now our heart is measured in relation to the total thoracic width, and this is referred to as the cardiac thoracic ratio. A CTR of greater than 50% is considered abnormal. So what happens is, to measure the cardiac size, you draw vertical parallel lines down the most lateral point of each side of the heart, and then you measure the distance between them. Now, to measure the thoracic width, you draw a vertical parallel line down the inner aspect of the widest point of the rib cage, and then you measure between them. Now our heart contour consists of our left lateral border, which is the left ventricle, and our right heart border, our right heart contour, consists of the right lateral border of the right atrium. Our aortic knuckle represents the left lateral edge of the aorta as it arches posteriorly down the backwards over the left main bronchus and pulmonary vessels. Now the contour of the descending thoracic aorta can be seen as a continuation down from the aortic knuckle. Unfortunately, as we get older, it tends to unfold, and then it becomes a lot more prominent with age. It's important to have a good quality chest X-ray, as this can really influence interpretation. First thing we want to look at is rotation. So you draw a vertical line down the centre of the vertebral bodies, T1 to T5. And you need to check that this line is equidistant to the medial end of the clavicle. If your patient is rotated to the right, it creates the appearance of a mediastinal mass, because what happens is that the manubrium or the superior vena cava or any of the vessels that arise from the arch of the aorta, they become really prominent. This is why you get this false appearance of a mediastinal mass. If your patient is rotated to the left, then what happens then is that the aortic arch appears enlarged, and then that creates the appearance of one lung being blacker than the other. Now, a good quality chest X-ray needs to have good inspiration, and we check this by seeing if we have 6 anterior ribs or 8 posterior ribs. Now the reason for this is that our diaphragm is attached to the undersurface of the heart. So as you take a large breath in, the muscle pulls the heart downwards. So what happens then with a poor quality inspiration? It creates the side-to-side diameter of the heart appearing much larger, and that creates a false impression of cardiac disease. Now, poor inspiration can also give the false impression of vessel crowding at the lung bases. And penetration, that needs to be adequate, because an underpenetrated image can create the impression of pulmonary fibrosis or edema. Angulation can project the clavicles over the apices, and then this can hide pathology. It's important to check on chest X-rays for the silhouette sign. Now, a silhouette is the outline of a solid object that's usually filled in black. To be honest though, the silhouette sign is usually a misnomer, because what it's actually referring to is the loss of the silhouette. On a normal chest x-ray, there are well-defined borders of the heart and the dome of the diaphragm, because the normal aerated lungs provide an interface. So if you have consolidation abutting one of these interfaces, then you lose the sharp margin of the heart or diaphragm. So, a blurred or missing interface is referred to as the silhouette sign. Okay, let's look at the silhouette sign, how it appears on the left lobe. So if we lose the left border of the diaphragm, this is due to lower lobe pathology. So think back to that lateral chest x-ray, where the majority of the diaphragm abuts the lower lobe. Loss of the left heart border. So this is due to upper lobe pathology, remembering that the majority of the heart border is abutted by the upper lobe. Let's look at the right side. So loss of the right heart border is due to middle lobe pathology. Now think back to that lateral view of the chest, where the majority of the heart borders are butted by the horizontal and the oblique fissures, thus surrounding the heart within the middle lobe. Now if we lose the right border of the hemidiaphragm, this is going to be due to lower lobe pathology, remembering that the majority of the lower lobe abuts the diaphragm. Some lung pathology can cause the anatomy to displace. So when we're evaluating this lung anatomy, we have to decide, has this been pulled to one side or has it been pushed away from the other? Now in this picture we have a pushed anatomy, where this massive pleural effusion has displaced the structures to the other side. So what happens is the diaphragm becomes depressed. And if we look at our ribs, there's widening of the intercostal spaces. Another example of pushed anatomy is a tension pneumothorax. And so what happens is the increase in pressure on the side of the tension pneumothorax, it causes the trachea and the mediastinum to be displaced to the side of less pressure. And the diaphragm of the affected side will be flattened. What is it? Pleural effusion. Where? Left lung. How? Large. Here we have an example of pooled anatomy, and this can be due to lobar collapse. So what happens is that the structures displace to the same side, and what happens is that you get an elevated hemidiaphragm and you get crowding of the ribs. Now on this x-ray the left side has been affected, so we see that the left hemidiaphragm is higher than the right. Remember, in a normal chest x-ray, the left hemidiaphragm should be lower than the right by about 1 costal interspace, which is about 2 centimetres. Now what lobe has collapsed? Think back to our silhouette sign. Remember, the majority of our lower lobe abuts the diaphragm, whereas our upper lobe is in communication with our heart border. Here we can see our hemidiaphragm, but we've lost the silhouette, the cardiac silhouette of the heart border. Therefore, this has to be upper lobe. What is it? Lobar collapse. Where? Left upper lobe. How? Severe. The following table contains the commonly used tubes and lines that we frequently perform chest x-rays for to assess for placement. I'm going to let you read through this by yourself. A correctly positioned NG tube should pass vertically down the esophagus and into the stomach. Now remember, the esophagus isn't visible on an x-ray. The esophagus passes posteriorly and just slightly left of the trachea. And the esophagus is located immediately to the right of the aortic knuckle. From the midline, the esophagus passes down the midline to the level of the gastroesophageal junction. And this is at the level of the diaphragm. So it's really important. A correctly positioned NG tube passes vertically down the midline or just left of the midline. Once you get below the level of the carina, it is absolutely important that the NG tube must not follow the course of either of the main bronchi and should remain within the midline, down to the level of the diaphragm, and from there it passes through the gastroesophageal junction. Let's have a look at the image on our left. If you follow the NG tube down, it passes vertically down the trachea, and once it reaches the carina, we then can see that it passes down our right main bronchus. Occasionally, our NG tube ends up coiled around our upper airway. You know, you need to see the distal tip of the NG tube visible on the chest x-ray. And it should be approximately 10 centimetres distal to the gastroesophageal junction. Equally, it shouldn't pass too far into the duodenum. So what is it? It's an NG tube. Where? Right bronchus and lung. How? Incorrect position. Our endotracheal tubes should be located 5 to 7 centimetres proximal to the carina. If the carina is not clearly visible, then our vertebral bodies can act as a landmark. Generally speaking, the carina is at the level of T5, although it can be between T5 to T7. Remember, if your patient's neck is held in extension, what's going to happen is that that's going to pull the tube superiorly. Conversely, if the patient's head is held in flexion, then that's going to push the tube inferiorly. Now, most ET tubes have an inflatable cuff, and they form a seal against the trachea. Now, we can't see these cuffs radiographically. If we look at our image on our right, we can see that the ET tube has been pushed down the right bronchus. So if this patient had their cuff inflated, that would occlude the left bronchus, and that's going to lead to a collapse of the left lung. The internal jugular and subclavian veins form part of the brachiocephalic veins. Now, the brachiocephalic veins join to form the superior vena cava. The superior vena cava is situated right of the mediastinum, just above and below the level of the carina. The central venous catheter should be positioned within the SVC at or just above the level of the carina. If you position the catheter too proximally, either within either the right or left brachiocephalic veins, this is associated with a much higher risk of infection and thrombosis. So our central venous catheter is vertically orientated. Our tip is projected over the anatomical location of the SVC, about 1.5 centimetres above the level of the carina. Now our PICC lines are used for long-term administration of chemotherapy drugs, and they're usually positioned much more inferiorly than a CVC. So they're usually at the level of the cavo-atrial junction. And this is approximately the height of two vertebral bodies below the carina. And this is often considered to be the long-term location for preferable location for long-term catheters. Come down here, just look at here. Think back to our slide on the pleura. The pleural space is surrounded by the parietal pleura and the visceral pleura. So pneumothorax forms when air is trapped within that pleural space. It may occur spontaneously, such as spontaneous pneumothorax, or due to underlying pathology. Trauma is by far the most common cause, and what happens is when the rib fractures, it lacerates the visceral pleura. So the three important features to look out for: a clearly defined line. So what this is the visceral pleura in profile, and this will parallel the chest wall. The upper part of the line will be curved at the lung apex, so it basically parallels the internal contour of the thorax. Overlapping ribs can be tricky, so keep looking through and between the ribs. And finally, an absence of lung markings between the chest edge and the wall. Primary spontaneous pneumothorax most likely occurs in healthy young adults between 20 to 40. The male to female ratio is 6:1, and they have no known lung disease. The cause for these spontaneous pneumothorax is due to the rupture of a subpleural bleb. So a bleb is an outpouching of the alveolar wall, where it bulges and thins the visceral pleural membrane. Generally, these blebs are present in the lung apices only. Secondary spontaneous pneumothorax is usually due to pre-existing lung disease, and that tends to be COPD, cavitating pneumonia, or pleural mets. Other pneumothoraces are caused by traumatic, iatrogenic, or other reasons. So blunt trauma, penetrating trauma from like knives, central line placement, lung biopsy, aspiration of pleural fluid, thoracic surgery, mechanical ventilation, acute asthma, or smoking cocaine or marijuana. Look carefully. You can see the thin line paralleling the chest wall, and then at the superior aspect it follows the curvature of the lung apex. There's no lung markings between the lung edge and the chest wall. So what is it? It's a pneumothorax. Where? Right upper zone. How? Mild deflation. A tension pneumothorax is a medical emergency. as air enters the pleural space, the normal negative intrapleural pressure becomes atmospheric. Now sometimes this valve-like effect occurs and the air continues to enter, but it can't exit the pleural cavity. So the pressure then rises above atmospheric. This build-up in tension causes compression to the inferior vena cava, and that results in obstruction to the venous return to the right side of the heart. And this is potentially and rapidly very lethal. So what you're looking at for signs for are that the ipsilateral drome is always slightly depressed and flattened. You have ipsilateral widening of the intercostal spaces, and the heart and mediastinum are usually pushed to the opposite side. So what is it? It's a pneumothorax. Where? Left lung. How? Severe deflation. We've come to the end of part 1, and we'll catch up again for part 2.